Imagine doing most things right. You're not bedridden, you're still working, life is busy, and nothing about your day-to-day screams emergency. Then one day your body drops a bombshell you never saw coming, a heart attack. Today we're talking about why that can happen even to people who seem healthy on the outside, and the quiet risk factor many Canadians have never even heard of.
And the wild part is that for a lot of people it isn't about being careless or ignoring obvious red flags. Sometimes the warning signs are subtle, easy to shrug off, or they don't show up at all. There's a specific blood marker at the center of this conversation, lipoprotein A, which most people hear as LPA.
Let's start with a story, because it puts this into perspective. There's a man in British Columbia named Darren Ollie. Back when he was 45, he felt something that didn't sound like a heart problem. More like an upper back discomfort. Annoying, but not terrifying. No dramatic chest pain, no sirens in his head.
And then, just a few months later, he had a massive heart attack. When he looks back, he describes it like pressure tightening inside the chest, almost like something stretching and squeezing from the inside out. And what he learned afterward is the part that makes you stop and think.
Because if he'd had one specific blood test earlier, there's a decent chance he would have discovered he had high LPA. Not a, maybe you ate too much fast food kind of number. LPA is mostly genetic. It's something you can carry without knowing it, and it can raise your risk of heart attack and stroke.
Here's the scale of it. About 1 in 5 Canadians are believed to have elevated LPA. That's roughly 8 million people. 8 million. And a lot of them don't know, because LPA usually isn't included in routine cholesterol screening and it doesn't reliably announce itself with clear symptoms.
So now you've got this invisible factor, affecting millions, sitting outside the standard checkup most of us rely on. That's exactly why a group of Canadian experts has been pushing for better awareness and clearer guidance, especially for family doctors who may not be dealing with LPA every day.
A Canadian working group recently published updated recommendations aimed at making LPA harder to miss. The big message is simple. Canadians should have a one-time LPA test in adulthood. One time. Not every month, not a complicated protocol, just a single measurement to identify whether you're in a higher risk category.
And when you think about it, the logic is pretty compelling. Heart disease remains one of the biggest causes of death. If there's a test that can flag risk earlier, why wouldn't we use it, especially when the cost of not knowing can be catastrophic?
Okay, so what is LPA, in plain language? It's a particle in the blood made of fat and protein that carries cholesterol. Everyone has some. The problem is when the level is high, because LPA tends to be extra sticky. It clings to blood vessel walls more readily than other cholesterol-related particles.
That stickiness matters over time. Picture your blood vessels as smooth pipes. Now imagine tiny bits of material catching along the inside, slowly building up. That buildup can become plaque, narrowing the vessel and restricting blood flow to the heart or the brain.
And it's not just about narrowing. Plaques can rupture. Clots can form. Arteries can become blocked. LPA is also linked with increased inflammation and clotting, which are basically 2 more ways to stack the odds against your cardiovascular system.
Some experts estimate that if your LPA is elevated, your risk of a cardiovascular event can be 2 to 4 times higher. That's a big jump. And it pushes us to the next question: what counts as elevated?
The updated guidance uses nanomoles per liter. If your level is 100 or higher, that's considered elevated. And if it's 190 or higher, you're in a much higher risk zone.
Now here's where people get frustrated. LPA doesn't behave like the cholesterol numbers you hear about all the time. It's largely genetic, and it tends to stay steady throughout your life. So you can't just say, okay, I'll eat better and my LPA will drop. That's not how it works.
There are a couple of life stages where levels can rise, like pregnancy or after menopause, but for most people, LPA is basically baked in. Which is why family history becomes such a big clue.
If someone close to you, parent, sibling, child, has high LPA, that's a strong reason to get tested too. And doctors also pay attention when certain health issues are in the picture: heart disease, stroke, dementia, kidney problems, obesity, fatty liver disease, even erectile dysfunction. All of those can be signals that it's time to look deeper.
And there's also a population risk piece. Research suggests people of African or Caribbean descent and people with South Asian ancestry are more likely to have elevated LPA. That doesn't mean everyone in those groups has it, but it does mean the odds can be higher, and odds should influence screening.
What's tricky is that you can't assume it's already being checked. LP(a) requires a specific blood test. It's not part of the standard cholesterol panel most people get during routine care.
So if you're listening and thinking, my doctor did my cholesterol, so I'm fine, it's worth asking, was LP(a) included? Many times, the answer is no, simply because it isn't routinely ordered.
You might be wondering, if it's genetic and hard to change, what's the point of knowing? That's where the conversation becomes really practical. Even if your LP(a) itself doesn't drop easily, knowing your risk can change how aggressively you manage everything else.
Right. There's also the treatment reality. Lifestyle changes like healthier food or more exercise won't directly lower LP(a). But they still matter enormously because they improve overall cardiovascular health. They reduce other risk factors that can combine with high LP(a) and create a perfect storm.
And while there aren't widely available medications designed specifically to lower LP(a) yet, research is happening. In the meantime, doctors often use statins. Statins don't reduce LP(a) directly, but they do lower LDL cholesterol, which can help reduce overall cardiovascular risk.
So it becomes a strategy. If one risk factor is stuck, you manage the others more deliberately. That can mean tighter cholesterol targets, more careful monitoring, and earlier interventions, depending on the person's full risk profile.
This is where that phrase comes in, knowledge is power. Not because knowing your LP(a) magically fixes the problem, but because it can change your decisions and your urgency. It can change what you take seriously. It can change how you interpret symptoms.
And Darren Ali's story brings that home again. He's now involved in a drug trial, which is pretty remarkable, turning his experience into something that could help future patients. But the part that sticks with me is what happened inside his family.
His youngest daughter has an LP(a) level that's even higher than his was when he had his heart attack. She's already on statins, and she's only 25. That detail is heavy. It's also exactly the point. If you can identify risk early, you can start protecting someone decades before a crisis.
So if you take one thing from this episode, let it be this question you can bring to your next appointment: can we test my LP(a)? Especially if you have a family history of early heart disease or stroke, or if you fall into a high-risk ancestry group, or if you've had unexplained cardiovascular issues.
A single blood test won't answer every question about your health, but it can reveal one you didn't even know to ask. And for millions of people, that could be the difference between living unaware and living prepared.
That's where we'll leave it today. If this episode made you think of someone, your parents, your siblings, your friends, share the idea, not as panic, but as empowerment. Sometimes prevention starts with vocabulary. Today's word was LP(a).
Thanks for listening. Take care of your heart, and don't be afraid to ask for the test that isn't automatically offered.